here is your graph of your night. And see all that? That's you not breathing. We should probably talk about what we're going to do about that.
Hi, welcome to the Medicine Couch, where we talk about the medical specialties and they help PAs and NPs learn about what their colleagues are doing and or help them find their fit in medicine. We talk about specialties all the way from the broad range specialties like ER or internal medicine, all the way to the other end of the spectrum where you have specialties that have a pretty narrow focus and that you can really become a master of a certain area. And we're going to talk about that end of the spectrum today and the specialty of sleep medicine. Today, I am joined by a nurse practitioner who actually calls herself the Sleep NP. She's going to give us an idea of what this specialty is like and who it might appeal to. So stay tuned.
My name is Carissa Hankins. I'm a certified family nurse practitioner. I'm a speaker and the founder of the Sleep NP.
What has been your path since you became an NP? Did you go directly into sleep medicine and stay there, or did you go into any other specialties?
So before I started in sleep medicine, I worked in a walk-in care clinic and an urgent care clinic. So 2011, I started in sleep medicine in Northern Maine. There is something to be said for going from like a walk-in care situation where you don't know what's coming through the door, you don't know any of the backstory, whereas in this kind of a specialty, people send you their information ahead of time. You have things to review. You can actually start formulating a plan before they even come in, which is kind of cool. And then in 2019, I was like, okay, it's time. We got to do something else. And that's when I transitioned over to pulmonology. And that was a huge whirlwind because I'd lived in the bubble of sleep medicine, which is awesome. But I felt like in pulmonology, I really upped my game there. I got to take all the sleep medicine stuff that I already knew about CPAP and BiPAP and portable ventilators and transition that over to the sickest of the sick, So it was really a wonderful marriage between the two things.
What conditions do you see on a regular basis in sleep medicine?
The number one diagnosis in sleep medicine is obstructive sleep apnea. And so we get people sent to us who they can't sleep enough. We even get some people who they don't think they have a sleep problem, but the cardiologist disagrees.
And probably their spouse.
Yes. I don't snore. I'm fine. Yeah, sure. So we do some parasomnias, but the baseline is generally ruling out sleep apnea because it can act like a lot of other things. So, if you're there for restless leg syndrome, well, okay, so what are the things that are leading to that or causing that? Because if you can fix those things, then you don't need the other things. Parasomnia disorders. So REM behavior disorder was a big one that we had. We had a adult population with a lot of farmers. We had a little bit of narcolepsy, not a whole heck of a lot of narcolepsy, which was kind of surprising because of the way the numbers are supposed to work out on that. But I've always found that one kind of difficult unless you had somebody with the classic cataplexy and sleep-related hallucinations and that just overwhelming excessive daytime sleepiness.
So you said you see, adults mainly. Do you ever see pediatrics, or is it strictly adults?
So in that practice, the physician and I, we did both see children. I think I saw as young as 5. Below that, we just don't have the sensors and the equipment to get good tests. So 5, 6, 7 was about the cutoff for that particular practice.
I don't know if you know this, but in larger cities and larger areas, I assume that there are strictly pediatric sleep centers, or do you think they're always mixed in with adults?
I have heard of such things, and I think they're awesome. But as far as I know, they're not so sleep medicine practices aren't that common. And then knock it down to under 18, that's going to be even less common.
True. Yeah. And I don't know how many kids actually have sleep disorders, but yeah.
There's a lot, I would think.
Well, yeah. Yeah. And I guess they probably have a lot of nightmare disorder too.
Well, would you be interested to know that ADD and ADHD have a connection with sleep apnea?
Oh,
So, and some of the behavior issues that kids will often have, some of it can be because they're not sleeping very well because they can't breathe well. And then we have cavemen who are, we're working with our not logical brains.
right. Yeah. Well, that makes perfect sense that if you're not, sleeping, that you act out. So with sleep medicine, I take it, or tell me if I'm wrong on this too, is it strictly an outpatient type setting, or is there ever any reason that somebody could be working in a strictly hospital inpatient environment in sleep medicine?
So, in order to get therapy covered, your patient needs to be in a chronic stable state. So we do not want them to be unstable. Can you get sleep testing while you're in the hospital? Yeah, some places will do it. It's just the quality drops significantly
Right.
when you add all the things and all the reasons people don't sleep well in the hospital.
When people do the sleep studies and they come into an outpatient sleep center and do the sleep studies, are PAs and NPs ever working those sleep studies? Like, does a provider need to be there overnight, or is that all handled by a technician?
There is supposed to be someone on call in case there's a question or a concern. All the labs I've ever worked with or heard of, they've all had protocols. So if X happens, then Y needs to happen, and call me for this and that sort of thing.
Yeah.
I only ever got a handful of calls on my patients, and it was usually like, what exactly are you looking for here? Or you had some strange special request, and I just want to clarify it.
Right.
But the sleep doc, he'd come in pretty early to read the studies, and he was always accessible to the technicians if something came up.
Most of the time, this is a very typical outpatient schedule, Monday through Friday, 8 to 5. How many patients roughly were you seeing a day?
It was 10 or 15. I had 3-hour-long consults a day, and then all the rest were 30 minutes. And then toward the end of my time, they were talking about doing the 20/40 schedule. So I have heard of some colleagues who are in sleep medicine now who are doing 20-minute visits, and they're seeing 18 or 20 a day by the sounds of it. It was interesting. In pulmonology, a lot of people would just get called with their sleep test results, and then, they'd be told like, yeah, you have sleep apnea, and the doctor wants you to start CPAP, and we've sent the orders. In my sleep medicine practice, like, you would come back and we would go over your results, and I would go, here is your graph of your night, and this is what everything means. And see all that? That's you not breathing. We should probably talk about what we're going to do about that.
And it's that was a little bit important that you're not breathing.
Yeah. And P.S., that's why you feel like you do. And we should see, can we get this fixed? Because if we can, then we get to see what's left over. We might not have to do anything else. That'll be awesome, right?
Yeah.
It was intentional to get people's buy-in, to make sure that they understood their diagnosis. Because if you go through it and you're like, I don't get it, this is dumb, you're not going to treat it unless somebody's making you, which is also not ideal.
Right.
So I'd usually have a follow-up just to go over results.
And so you said something about the doc would read the sleep studies. Did you ever get the point where you interpreted, or does the doc always have to be the one interpreting the sleep study?
So to be able to put your name as the person who is reading the sleep study, you have to be a physician, and you have to have gone through the fellowship process and all of the certification things. And those things don't even exist for advanced practice providers.
Yes. Yeah.
Now, give me a hypnogram, I'm your girl. But that's secondary data from what had been scored from the lab.
Yeah. Okay. And then what about like autonomy in the clinic, where you said you had consult appointments blocked out? So were you seeing new patients that came into the practice, or did they always see the physician and then they were new to you and you did follow up?
There were patients that never physically saw the doc. So I did see new patients. Since my doc, he was the only one reading studies, he would read all the consults anyway because he's doing their studies.
Yeah.
But yes, as far as being able to practice independently with collaboration. Like, here's my plan, here's what I want to do. That was an accessible thing in that particular job. I worked up to it though. Like it was at least, it was probably a good 4 to 6 weeks, I think,
Yeah.
before I started seeing patients on my own.
I don't imagine that you would, but are there any procedures that you do in sleep medicine?
No procedures. Probably the most time intensive thing would be the sleep diaries that go with a testing for narcolepsy. You have to rule out or do the best you can to rule out anything else that could possibly be causing this person's symptoms. So we try to get a good handle on what's the sleep pattern. Is there enough sleep? Like, should this be enough sleep? But no actual procedures. So it's not a hands-on kind of specialty.
Right. Yeah, it sounds more like you're kind of being a detective trying to figure out what is the problem with their sleep. And I imagine there's a lot of patient education time spent.
There is a lot of patient education.
Yeah. What about medications? Do you prescribe much?
Are narcoleptics? Yes. They have a certain protocol of medications that they can do. I'm not a big fan of, and this is my physician's preference, and I've kind of seen it play out in clinic. I'm not a big fan of prescription medication to put people to sleep.
Yeah.
It's incredibly difficult to get them off, and it gives them like an unrealistic expectation of what sleep should be. The other scenario for medications would be restless leg syndrome. And we actually did some stuff with melatonin for REM behavior disorder, so we wouldn't have to go the controlled route. And that seemed to work actually pretty well for folks.
There are definitely lots of places that don't have dedicated sleep clinics, so it's handled in pulmonology. From just your experience or what you know about the field, do there tend to be providers that are dedicated to sleep study within pulmonology, or does everyone seeing a little bit of sleep apnea sprinkled in everywhere?
I think it's going to vary based on the providers who are present and what their comfort level is. When I was in pulmonology, I was the one I was like, I'll go over all your sleep test results and I'll get all your patients started on CPAP, and then I will send them back to you and you can do your thing. But not everybody does that.
Yeah.
So, I mean, there had been people who were referred to pulmonology just for their sleep apnea, and they get to the pulmonologist and he's like, I don't like sleep apnea. You can see Carissa. She'll handle it. She'll hook you up.
Yeah, so it sounds like an opportunity if you learn sleep medicine, you've been in sleep medicine for a while. It sounds like that if you move like to another, city or whatever, and there's not a dedicated sleep clinic, that you could kind of carve out your own little niche inside a pulmonology clinic.
You could even do it in primary care, because there are loads of people who have a CPAP machine or who need a CPAP machine, and the process doesn't have to be super complicated. So even in primary care, there could be a role for having a sleep focus.
What things, if any, were kind of a surprise for you about sleep medicine once you moved into it and started practicing?
I think probably the biggest surprise is that sleep apnea is everywhere, and it has its nasty little fingers in just about everything. So there's all sorts of things that people don't even realize that sleep apnea is messing with or contributing to or associated with. And that was the biggest shocker.
What are some of the things that you really love the most about this specialty?
I really love when they didn't look good when we first saw them. And I really love it when they come back and they've gotten their win, and they're feeling better and they're doing better, and their laundry list of problems that were driving them crazy has pretty much just dried up. And so I love being able to be in something where it is treatable. I mean, in pulmonology, we had stuff that was treatable, but not really, you get what you get, and that's as good as it gets. But in sleep medicine, there definitely is that opportunity to really get people doing a lot better.
So non-compliance, I would imagine, is a big problem in sleep medicine. Just knowing the patients that I've dealt with in family practice that complain about that their masks or sleeping with the CPAP. But just in general, what are the biggest drawbacks or the negatives to working in sleep medicine?
Not everybody wants to be there. It is a big one. But the thing I don't like is there seems to be a lot of fear based on the unknown. So everybody who, oh, I'm not going to get a sleep study because, oh, I can't do the mask thing, or I wouldn't be able to breathe. There's a lot of I can't stuff and a lot of fear.
And when you said people don't want to be there, why are they there and they don't want to be there?
Well, if you are a commercial truck driver and you have a high risk based on your history and your physical exam for sleep apnea, you are on the hook. And if you don't have your sleep apnea treated, then you don't get to drive. So in answer to your question, the people who don't want to be there, usually those are the ones who had their license taken because they did not want to treat their sleep apnea. The truck drivers and bus drivers, there is a very large theme, I guess, of them feeling like we're saying they are unsafe to operate a motor vehicle. And my response to them is, you know what? I'm not saying you're unsafe. I'm saying that if you're going to have a heart attack or a stroke, it's not going to wait until you pull over. So I'm saying that this is a health problem and it does have ramifications for safety.
Did we talk about all the things that you love about this specialty? Is there anything else that you love or hate that we didn't mention?
You know what I really hate? I do not like how in all the EMRs I have used, I can send a prescription to a pharmacy with one click of the mouse. I cannot do that for CPAP.
Mm.
We have to have the face sheet, we have to have the prescription, we have to have the sleep study, we have to have the consult, and then I have to chase paper. I do not like that part.
Yeah. Do you have a lot of prior authorizations? Like, do you have a lot of fights with insurance companies?
Yes, insurance does not like certain things. And we have had folks where that's just their job, is just to get prior authorizations. And some insurances, you can do it online, and some they make you go through the phone maze. And then when you get to the end of the phone maze, you have to start again with the next patient.
What kind of personalities do you think do well in this field?
Well, if you are looking for an adrenaline high, this is not the place to go. But if you like a controlled environment where you have some idea of what's walking through the door and you have a limited menu of things that you're going to be addressing, then this is for you. It's also for you if you're somebody who wants to know a lot about a few things instead of a little about a lot of things.
Did you find it overly boring or repetitive, or was it always something different just because every patient is different, even if they're kind of being seen for the same thing?
Well, round about the 5-year mark was when I started going, okay, this is kind of getting to be like Groundhog Day. And so yes, it does have that potential.
Right.
And but that's also why it would adapt well to other types of practices that are more general. So then you can have a little more spice in your life if you want it.
So if somebody's watching this, they're already a PA or an NP and they've thought about sleep medicine, or they're hearing this and I think, that might be a good specialty for me. What kind of things would you advise people to do to help prepare themselves to be a good candidate to get a job and to be able to walk into this specialty?
I would say use your CME money to take one of the sleep courses that's available online. When I first started, I went to the Atlanta Sleep School, which I don't think they're doing much at this point for advanced practice providers. The Pulmonary and Sleep Academy, I did the pulmonary lectures and I was like, wow, this is awesome. And the sleep content, I haven't done it, but it looks very good. American Academy of Sleep Medicine also has some trainings for advanced practice providers, because you really, if you're going to be going over somebody's sleep testing, you need to be able to be familiar with what are you looking at? What does it mean? Because there's nothing like looking at something and going, yes, the AHI is 7. What's the AHI? I don't know, but it's 7. So, but training, doing that self-training is huge, because even though I had a fantastic experience getting trained on the job, a lot of places are kind of at the point where they're probably going to want somebody who they don't have to train. So if you already go in knowing some things, you're not going to know everything. You still have training wheels. That's okay. But if you go in knowing some things, that's going to be helpful.
Yeah. Yeah. And it'll help on your resume to be able to put that you've gone through these courses. So education is a huge part of what you do. And I know that you have a website and you call yourself the Sleep NP. Tell us a little bit about that and kind of what you do on your website.
In 2020, I started doing some speaking for a Facebook group that's focused specifically on advanced practice providers, nursing, and first responders. And I was like, oh, I need to like put this into something. And I thought, oh, yes, the sleepnp.com. That would be great. I could just kind of funnel it into there. So right at this point, the focus of the Sleep NP is largely CPAP, sleep apnea. I do actually have a freebie associated with it. It's 4 ways to accelerate your CPAP success. Okay. And it's the things that I tell my patients, like, if we got to get this going, if this is gonna, get traction, if you're gonna like be able to be a boss with it, these are the things that need to happen. And so it's a good resource, whether you're a provider or if you're the one who's staring down a mask and a machine.
Yeah. Okay, well, I'll put the link to your website down below if people want to go check that out. Going back to talking about the specialty itself, is this something that you think is new grad friendly, or do you think that people should really work as a provider in maybe primary care or something first before moving into such a narrow specialty?
I think it's going to depend on what are your overall career goals. And my path has been awesome because I went from sleep medicine to pulmonology, and you can do a lot with both of them together. So yes, good place for new grads, but even though it's a very stable kind of a specialty, you still always have that first year newness. Yeah. So having support helps. If the place is like, here you go, jump off the deep end, that's probably not where you're going to want to be as a new grad. But if it's going to be a supportive environment where, you could just knock on your doc's door and be like, all right, here's the deal, and not feel dumb about it, then that would be perfect.
So anything else that you want to say about sleep medicine, anything that you think people should know about, or your final thoughts on the topic?
I love sleep medicine. It is totally my jam. I mean, I get to help people to feel heard. I get to help them feel better. And I really get to make a difference in people's lives. And, for something that not a lot of people really know about, it's a huge honor and a privilege just to have had this experience and to be able to transition it over to pulmonology and transition it over to other things.
Yeah. Well, great. Well, thank you so much for joining us, Carissa, and for sharing your knowledge with us.
Thanks for having me.
All right. Well, I can definitely see some of the appeal in sleep medicine, but if sleep medicine doesn't sound like the right specialty for you and you're still kind of looking and want to see what different options are, then you can watch these videos here where I talk with PAs and NPs working in the various medical specialties. Thanks for joining me today. Take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.